I'll invite now Dr. Bhavin Visaria for the next paper. He's a senior consultant at HCG Mumbai, radiation oncologist.
Good morning. So today I'm talking about 5-year efficacy and toxicity of focal boost in SBRT in prostate cancer. I'm discussing about this trial, Hypo-FLAME trial, which was published in 2024 in the Green Journal. Prostate cancer being a problem statement, it is one of the commonest disease, which is one of the commonest cancer which is seen in the elderly male. And radiation has become a standard of treatment for the prostate cancer. In radiation, we have evolved from a treatment which was spanning over 8 weeks to then 4 weeks and now 5 days SBRT. So the rationale of doing this treatment was to dose escalate by doing a combined biological dose escalation using SBRT, as well as doing a physical dose escalation by giving a focal boost to the tumor lesion. And then it was based on the data of the FLAME trial, where the same thing was done in the conventional fractionation, where the 95 gray was given, which had shown improvement in the disease-free survival, biochemical disease-free survival. So this study design was it's a multicentric trial, phase 2 trial, of which we have study had 100 men, 75% were high risk, 25% were intermediate risk, and the inclusion criteria were all standard. Visible lesion in the MRI, PSA of less than 30, Gleason score of 7 or more, and no metastatic disease. The treatment was given such as that 35 gray, 5 in a 5 fraction, 1 fraction per week to the whole prostate, and the focal boost was given 50 gray, which was isotoxic, prioritizing OAR constraints, especially urethra, and the ADT was given in almost 62 2/3 of the patients. The endpoints were, primary endpoint was acute toxicity, which was previously published, and the secondary endpoint was 5-year biochemical disease-free survival, late toxicity, and the quality of life index. So when we look at the result, the efficacy wise, the efficacy 5-year biochemical disease-free survival was 93%, which is comparable to 95.7% in the phase B intermediate risk category. When we look at the recurrences, there were 6 recurrences. Most of the recurrences, there were 2 recurrences which were isolated regional recurrences. There were 4 recurrences which had a distal metastasis, of which 1 had a local recurrence also along with the distal metastasis. When we talk about the failures, the failure was a function of the near minimum dose, that is the amount of dose which has been received by the GTV of D99. The higher the dose, it reduced the biochemical failure. When we talk about the toxicity, the cumulative grade 3 toxicity in the GU category was 2%, whereas grade 2 toxicity 5 years was 12%. Similarly, the GI toxicity was also minimum. The grade 3 or more was 1%, and grade 2 for 5 years was 4% only. When we talk about return of function, bladder, the mean quality of life for the bladder bother was returned to baseline after 6 months. Whereas bowel, there was a significant difference between bowel function mean score at the baseline versus 5 years. In the sexual activity, there was no difference in the sexual activity baseline at the end of the 5 year. The strength of this study is basically it has defined a high risk focus. So 75% of the high risk patients were here as compared to phase B. The focal boost integration was well planned in this particular study, where it has shown that 44.7 gray can be given without increasing any toxicity, and there was a synergy with the androgen deprivation therapy, which potential contributor for the high disease-free survival. In comparison to the previous FLAME trial, the biochemical disease-free survival of 93% versus the previous FLAME trial where conventional radiation was used was 92%, which was comparable. When we talk about the weakness of the study, it's a non-randomized trial design, it's a phase 2 design, GTV delineation, there are imperfections with respect to MRA-based target delineation, and the whole gland dose was only 35%, whereas the 36.25% is the standard right now. To conclude my presentation, the Hypo-FLAME study demonstrates there is a very good efficacy, 93% 5-year biochemical disease-free survival, predominantly in high-risk patients, and the late toxicities are minimal. It supports focal boosting as a strategy to enhance the SBRT without compromising on the safety. So the final message is Hypo-FLAME bridges the ultra hypofractionated and focal escalation, offering a promising paradigm for a high-risk prostate patient. The clinical implication of this study is, yes, it can be used in a high-risk patient. It balances the efficacy and the safety, and the cost and logistic, because we are asking patient to come only for 5 days. It reduces the cost and logistics also. When we talk about the future direction, this is where we are heading from standard treatment of 35 to 38 fraction to 20 fractions now, where we are giving a similar dose to the entire gland, including focal, including the lesion, versus a different approach where we are using SBRT and we are giving a higher dose focal boost to the lesion to improve the biochemical failure-free survival. Thank you.